All right, welcome back. And this is chapter 13 of nutrition. So let me share my screen and let's get to it. So this is nutrition care and assessment. Make that screen a little bit bigger so you can see it better. All right, so let's take a look at the learning objectives and see what we're going to talk about. We are going to describe interrelationships between illness and malnutrition, and explain how health professionals identify and treat patients that are at risk for nutritional problems. We're going to talk about different types of data that we use to evaluate somebody's nutritional status and health status. We will explain how nutritional and genomics research may improve our understanding of the relationship between illness and nutrition care. Genomics is fascinating, absolutely, utterly fascinating. The human genome and how it affects everything that we do, the things that we eat, how we look, how we feel, our emotions, just everything, how drugs react with us, fascinating, fascinating, fascinating. All right, so let's get started. Illnesses and the treatments for illnesses can lead to malnutrition. Just think about if you've ever known anyone with cancer that had to receive chemo or radiation, right? That chemotherapy attacks quickly proliferating cells in the body because cancer cells grow quicker than other cells. Other than cancer cells, the fastest growing cells in your body are your hair, your nails, and your digestive tract, which is why chemotherapy makes you vomit and makes your hair fall out. Makes sense, right? So, when people are getting treated for illness or they have certain illnesses, there can be a reduction in how much food they take in. There can be something that interferes with their digestive tract or their absorption. And there can be changes in their metabolic rate or their excretion. And so dietary changes that are required for really acute illnesses are usually temporary. But if they're chronic illnesses, then it can be something that, they have to adapt to for a lengthy period of time. So there's a chart here on this fourth slide that kind of talks about the ways that illness affects our nutritional status. So for example, something like reduced food intake, well, anorexia, and don't confuse that with anorexia nervosa. So that's a psychiatric diagnosis. The word anorexia simply means loss of appetite. And so patients can have anorexia because of illnesses, because of nausea, because of vomiting, because it hurts when they eat, or there's a problem with something in their mouth. They have difficulty chewing. Maybe they had a stroke and they can't swallow, right? All these things can lead to nutritional deficits. And what do we do about it? So there are different treatments, like we can change their diet. Sometimes we'll give them something called TPN, total parenteral nutrition, which is nutrition through an IV, and give their digestive tract a complete rest. Lots of different things. If they have impaired digestion and absorption, usually it's something to do with their bowels. It could be something with the gallbladder, it could be the intestines, pancreatic issues, digestive enzymes aren't being produced, lots of different things. And altered nutrient metabolism and excretion, usually that's a metabolic problem. So in other words, prolonged immobilization is not metabolic, but it can cause a metabolic problem. So in other words, if you're bedridden for a lengthy period of time, that can actually alter your nutritional status because it alters your metabolic rate. It'll slow it down. So lots of different ways that nutritional status is affected by our state of health. And so whose responsibility is it for nutritional care? It's not just dietitians, it's nurses, it's physicians. Physicians are the ones that actually prescribe the dietary orders for the patients. So you can't, administer any type of food to a patient until you have an order from the physician. And then there's something called clinical pathways. In nursing, we also call them care plans, if you guys have ever heard of those. Mm-hmm. And basically what it is, it's like a coordinated interdisciplinary plan for specific diagnoses, treatments, and procedures, and what are the interventions that we can provide to help patients attain the goals that we're trying to set for them for wellness. Registered dietetic technician, you don't really see those. I don't think I've ever in my career seen one. They do exist, it is a thing, but they're the ones that help to implement the nutritional services that the dietitian puts together for the patient. And then here you go, nurses. We're responsible for tube feedings, IV feedings. we're responsible for nutritional care if the facility doesn't have a registered dietitian. We are the dietitian. And honestly, I mean, one of the biggest things that I've always spoken to patients about is nutrition, because you are what you eat. I say that all the time. And then other healthcare workers, you know, it's like a team effort. And so other healthcare workers, they may identify something and they can bring it to our attention so that we can address it. Risk for malnutrition. So there are different standardized tools that we can use. One of them is a subjective global assessment. Basically, what we do is we look at the patient and we get what's their admitting diagnosis. What are their physical measurements? In other words, what's their height, what's their weight, and any lab test results. Particularly, we look at things like albumin and pre-albumin. Those are plasma proteins. They're good indicators of someone who's malnourished if they're low. And we get information about the nutritional status and health status of the patient from the patient, and maybe also from their caregiver or their significant other. And so the criteria that we use to identify the risk for malnutrition: what is their age, their diagnosis, severity of illness or injury, right? When we talk about anthropometric data, that is, you know, standardized data like their height, their weight, their BMI. Have they unintentionally lost a significant amount of weight in the past, like 6 months? Has there been loss of muscle or subcutaneous fat? We'll do a functional assessment. What's their hand grip strength? You know, how strong are they to be able to get up and down, ambulate, right? Is their mobility impaired? And then we'll look at their history. Do they have diabetes, renal disease? What medications are they on? What food allergies do they have? Do they have dietary restrictions? Are they isolated? Do they eat alone all the time? You know, are they demented, confused? We look at blood tests. Like I said, we talked about that. And signs and symptoms: reduced appetite or food intake problems that interfere with food intake. It can be chewing, swallowing, so many different things can be a factor in why someone is malnourished. So we kind of have to try to work together to identify what the problem is. So in the nutrition care process, which is what they call it here, there are 4 distinct steps they lay out. So first is the nutrition assessment. So the goal is to identify what are the specific problems for that patient. Then we come up with a nutritional diagnosis, and that's kind of like a nursing diagnosis. It's formatted as a statement that includes the problem, the etiology of the problem, and what are the patient's symptoms, right? Then there's the intervention. What can we do to intervene and alleviate whatever the problem is? And then monitoring and evaluation. So did it work? Did the plan that we put in place work? And if it did, great. And if it didn't, then we modify it and we start all over again, like back to square one. And so there's a little flow chart here that shows the nutritional process that I just spoke about. And so with nutrition assessment, like I said, I don't want to be redundant, but you want to ask a lot of questions. When I do admissions, I mean, I really delve into everything that I can possibly find out about that patient, you know, to figure out what's going on and what I can do to help them, you know. What are their personal preferences, even that, you know, some people don't like certain foods or are very picky eaters, right? So lots of things to know. Are they taking supplements? What's their social history, right? What is their nutritional history? And then we've got this other table here that goes through all the information that you need, even things that you might not think are important, like somebody's educational level, believe it or not, has an impact on their health status and has an impact on their nutritional status. Their job, do they work nights, right? Is their life kind of upside down? Do they smoke? Do they drink? You know, do they, you know, smoke crack? Because that's not good ever to do that. I don't think so. Do they have any food allergies or intolerances? Are they socioeconomically depressed? In other words, can they afford to eat? I had a lady in the ER that had been eating cat food because she couldn't afford her meds and food. And that's really bad because cat food has so much protein in it, too much for humans. And she was in bad shape. One of the sadder stories that I saw. So, you know, lots and lots of questions to ask people. If you can, you try to ask somebody, hey, just for example, what'd you eat in the last 24 hours? Like when you guys did that dietary analysis, a lot of you were stunned by what the results were. I really enjoyed reading a lot of them because you were like, I thought I needed less and it turns out I need more, or I thought it wasn't what I thought, right? So it's always good to start out to ask people, just what'd you have for breakfast this morning? Or what'd you eat yesterday? And what kinds of specific foods do you typically eat? Because people generally will have a pattern of certain foods that they like or that they eat all the time, and beverages. We'll tell them to keep a food record, just like you guys did the dietary analysis, but for longer than 2 days, usually for a week. Write down everything that you ate so we can kind of look at it and talk about what better choices, could be made. Body size measurements. So that can reveal problems about malnutrition and overnutrition. So their height and weight. And you can estimate it once you've been doing something in the medical field for a minute. Like I can look at people and generally come pretty close to their height and weight. Some people are deceptive, right? Sometimes I'll be off, but generally speaking, I can come pretty close. And people's weight can change because of things like loss of fluid volume, right? So for example, somebody with congestive heart failure, they can gain or lose 3 pounds or 5 pounds overnight, but that's not fat. That's not body mass. That's fluid, right? So that's different. And we also look at things like the circumferences of the weight. It says head, waist, and limbs. The waist is one of the big ones, and the mid-arm circumference, we call it a MAC, gives us some indicator about loss of body mass, believe it or not. So right in the middle of the upper arm, right where your bicep is, you get a tape measure, and with the arm relaxed and at their side, and you measure that, and that kind of gives you a baseline. And waist circumference, according to so much research, is a predictor along with body type for different types of illnesses that people can be more susceptible to than others. When we look at the anthropometric data, so like, for example, anybody that's got kids knows that when you take the kid to the pediatrician, what does the pediatrician do? They weigh them, they measure them, and then they tell you what percentile of growth they're in, right? So why do they do that? Because they want to make sure that they're at least within normal limits range, they're not falling behind. Any child that's under the 5th percentile, you would be worried. That's really low. So, what's the problem? Is it genetics? If it's not genetics, like maybe they're just small people. My daughter-in-law's 4'10". She's a little tiny little girl. But, or is there a problem? Is that child malnourished or something? And when we look at the higher end, usually around the 85th percentile can be used to identify overweight people. However, and I'm adding this in, my kids were in the 99th growth percentile, all 3 of them, always. They were big, but they were never overweight, right? They were old. 6'4", my son is 6'4", the other one's 6'2", daughter's almost 5'8". So they're big people, big kids, big babies, not necessarily overweight. The other questions that are important are lifestyle. How much TV time? How much exercise? Are you going outside? Are they going outside? Or are they sitting most of the day? When we look at weight loss, we look at the percentage of weight loss versus just the number of pounds, right? Because it's important to understand, I want to lose 20 pounds. 20 pounds for me would be a lot of weight to lose. 20 pounds from someone who weighs 240 is not a lot of weight to lose if they're 5'10", right? You get my point? So the percentage is far more important than the actual number of pounds when we talk about weight gain, weight loss, right? And measuring skin folds, and that's always fun. For people that are very obese, they can have multiple folds, and you have to really see like how deep is the fold, right? And you actually would measure that for a lot of different reasons. One reason for hygiene, because fungal infections love a warm, dark, moist environment. And those skin folds are warm, dark, moist environments. And then the other thing is where is most of the weight being carried? different people carry weight differently on their frame. Some people, when they gain weight, they gain it in the middle. Some people will gain it everywhere. So all these things have to be like taken into consideration. When we look at the anthropometric data, we look at these numbers. This gives you like what the risk is. So I'm looking at a chart here that says, if your IBW, which is the percentage of body weight increased, or the UBW, which is the under body weight percentage, you can be at a mild risk of malnutrition, you can be at a moderate risk, or you can be at a severe risk. Generally speaking, when you're at the 70th or 75th percentile, in other words, if you've lost 75% of your recommended body weight, or you've gained 75% of your recommended body weight, you have a problem. That's very severe, right? That makes sense, doesn't it? Biochemical analyses, things like blood and urine. We look at proteins, like I said, albumin and pre-albumin. Sometimes they're not wholly accurate, but they're useful when you use them with other tools to kind of come to a conclusion about a patient and come up with a diagnosis. Serum protein, here you go. I already said it, now it's on this slide. Albumin, transparency, reactive protein. These are the different lab values that we use to look at, what kind of nutritional status the patient is in. Physical examination. Physical signs of malnutrition are kind of vague and ambiguous. They're not very specific. But really, the first things that you see are the skin, the hair, and the digestive tract, and also body shape over time will change. Like if you look at children that are in an area where there's malnourishment, they can have things like rickets, because of vitamin deficiencies and those kinds of things. So physical examination is important. Also, physical exam can tell you someone's hydration status. Simple thing like asking someone to open up their mouth and say, are their oral mucous membranes moist or dry? If they're very dry, that can be an indicator of fluid volume deficit. They could be dehydrated. How much water did you drink today? Do you drink water? And in functional assessments, a zinc deficiency, those are kind of extreme. You don't really see those as frequently. But we look at things like their hand grip strengths, to see, are they getting enough vitamins and minerals and protein and so on and so forth? Is their diet nutritionally sound to give them at least the average amount of strength, right? Can they maintain their balance when they're walking, right? Those kinds of things. And then the genomics, right? So microarray technology, they can look at thousands of genes at the same time, and they can look at regions of, regions of genes. So that turns a certain expression of the gene on or off. So in other words, makes a particular gene do a certain function in the body. Like I said, genomics is absolutely and utterly probably the most fascinating thing for me that I've ever, read about. No two individuals in the world are genetically identical. Nobody. Identical twins because they come from one egg, right? So yes, other than that, no. The variation in genomes of any two individuals is about 1 to 3%. And most disorders that people have, most, I can't say all with conclusivity, but most are influenced by different genetic factors. Some stuff from your mom's side, some stuff from your dad's side. So, but you can fight your genetics by doing the right thing, like watching the things that you eat and getting exercise and those kinds of things, right? And that is the end of chapter 13. Drop the mic. I'll stop the share and I'll stop the record.